this is the housekeeping announcement. I saw some of you are still willing to discuss, but because of the time limitation that the other symposium session has already started, we may have to start the symposium session right now, and then you can, if we have extra time after the symposium, we will invite you to discuss later. Okay, now let's welcome the moderator of the next symposium session, Professor Meifeng Lin.
Thank you. Good afternoon. Is the voice how's the voice quality?
It's good, Prof. Lin.
It's good.
Okay, thank you. So today we have 4 presenters in our nursing symposium, 3 from Indonesia, 1 from Sri Lanka. That's a great chance to meet you.
Thank you.
On internet. So I saw some of our participants. Stay with us, please. Welcome and join with us. So our presentation focus is focused on how we facilitate the nursing competence as a psychiatric nursing domain. So as you saw, Professor
Akhiliani.
Hamid. Professor Hamid is a full professor from University of Indonesia. She is a great leader and leading lots of revolution and also well-established program in psychiatric nursing. It's our great honor to have Professor Yani join with us. So that's welcome Yani's talk. Her speech is focused on the enhancement of Indonesian nursing competence, especially from mental health perspective. Let's welcome Professor Yani.
Thank you so much, Professor Lin. It's been nice to meet you through this virtual meeting forum. Yeah, I would like to share with all of you about the enhancements of Indonesian nursing competence in disaster situation from mental health perspective. Perhaps I would explain more on national Indonesia as national perspective. So the content would be development of nursing's practice standard on disaster risk management that we have developed, and then training need assessment to identify the gap of competencies, and training module and models that we have been developing, and integrated mental health in expected role of nurses in disaster. So as you understand that Indonesia is the largest archipelago in the world with 5 major islands consisted of more than 17 million islands, and our population is 273.5 million. So we have a very variety and different ethnic groups and different local languages and then different religions with the majority of Muslim. And taking into this perspective that it is very important to know that nurses as the health professional majority in Indonesia consists about 50 to 60% of health professional. We need to be competent, to be knowledgeable, and have the high capacities of intellectuality and practice skill, integrity, and professional and ethical values, which is required for safe and accountable and effective practice. And as you know that in Indonesia, we already have the Nursing Act, particularly for nursing profession in Indonesia. And then it is also supported by the Mental Health Act, which has been already issued in 2014. So taking into that account, then we also came to get the insight about the Sendai framework outcome, that we not only to prepare to respond, but we have to prepare ourselves as the majority of nurse health professional providers, that how to reduce the disaster risk and loss in life, in livelihood and health, and in the economic, physical, social, cultural, and environmental assets of persons businesses, communities, and countries. So this center framework gives us insight that there are a lot of things that we have to do. One of those things is very strategic, is to develop the nursing practice standard on disaster risk management for health. So taking into this account that nurses play a very important role in disaster risk management for health, and then we know how the risk management is very important to respond to crisis management and to be more prepared, so we will reduce this disaster risk and impact. And what we have done, and then it is already in our plan, and we have been undergoing this process since 2017, we have identified the indicators for good nursing practice through our study. And then in October 2017, we would like to match this and sharing with Japanese research team, including Dr. Hiroko Minami team, on findings of good practice, whether we come up with the same thing. And in 2018, we developed and modified the nursing practice standard of ICN, and then also modified through disaster risk management for health, taking into account the best practice or good nursing practice perceived by the important resources. And in 2018, 2020, we did already training need assessment, and now we are developing the model and modules for training nurses to meet the standard. So we expect that in 2021, we can conduct training for nurses. Who knows, we can work together on these activities. And so it requires exploration of best practice from relevant resources, person, and studies. So we can identify from many perspectives what is meant by best practice in nursing. So it can become as a component or indicators of the standard that we develop. So when we talk about the resources, we also consider and involve in our study the survivors, the one who directly affected by disaster or pandemic or whatever. And the second one is the community at large, who are affected because they watch the news and then they've been observing, but there is a psychological effects on them. And then the rescuers or responders, including nurses as a responders, who are likely to be exposed to trauma and saying other suffers as well as fear for their own well-being. So these three main sources of information that we get the perceptions what is really the good practice is. And then this is the study that we did together with the research team of Faculty of Nursing, faculty members of University of Indonesia, that this is only one of different places that we have take as a sample for our study. This is in Yogyakarta, which will be exposed more by Dr. Hemi Susanti in detail. But we really, come to the conclusion that only 10% of nurses who perceive that they are competent, to respond to disaster. And then less capable 45% and quite capable 45%. So it means that a lot of things to do. We need to prepare them better through trainings. So this is things the express key principle as nurses working in disaster. Coordination come up as a key word. And then also they're being fair because they are bonded by the code of ethics as a nurse. They should not discriminate the people that they help, even they discriminate the people and their own family. So they have to act based on data. And this is very important to show that nurses are accountable to the practice that they are provided. So for development of nursing practice standard of disaster risk management, we did the research in Yogyakarta that for volcanic eruption, in Jakarta for flood, and then for West Sumatra earthquake. It will be explored more by Dr. Hemi Susanti later. So we come up with 14 indicators of good practice perceived by different resources. And then we have come up with discussion with the research team from Japan who add another 4 indicators of good practice. but then we try to incorporate it, integrate it, become 13 indicators. So we develop the nursing practice standard or disaster risk management is still in Bahasa Indonesia. So to come up with the training needs assessment to identify the gap of competencies. So from these 13 category or indicators of standard, then we look at the means, to see that between 1 to 4, if it is closest to 4, it means that they feel capable of doing that indicator of good practice. But then when you see this from number 9 to 13, integrating values and culture in the community until government advocacy, this is the list of competencies that the nurses perceive that they are not so much capable of. So, but when you look at the indicator perceived as most competent by nurses, I'm so happy to share with you that they are competent of providing nursing care to grieving family. So it is a lot of psychosocial and mental health interventions in it, integrating mental and physical nursing care, and facilitate family functions. So these three as the highest perception that they're capable of. And this is the last 5 of the 13 indicators. So that they feel uncomfortable of, that they feel that there is a less competencies that they have. So the first one is integrating values and culture in the community. The second one, cross-sectoral coordinations, and then lead and manage the situations, managing corpse or dead body culturally, and government advocacy. When you're looking at it at the glance, it shows the leadership skills and the ability to influence or impact others, and also the bureaucracy, the governments are very needed to be prepared to the nurses. So this is the main topic of training modules after some discussion of the team research. Then we come up with the 4 topics. The first one is coordination, collaboration, communication, and advocacy in disaster cycle. When we talk about communication, information is in it. And also leadership in leading, managing, and empowering the client systems. This is including individual, family, community, and responders in disaster situation. And the third one, the modules that we are preparing is integrating values and culture in the family and community. And the fourth, managing corps and family culturally sensitive. So this is 4 main topic of training modules are still undergoing the process of development. And point 4 and 5, integrate values in culture, family, and community. By integrating psychosocial support and mental health interventions, we see that what they're doing is that when we need to integrate the integration of psychosocial aspect in physical nursing care. The psychosocial intervention cannot be wait until they are really safe physically, but it should be integrated so then there will no PTSD, no post-traumatic stress disorder or stress syndrome, because we have in the beginning identified already what the psychosocial needs, how they grieve, and how we can make a support to them. So there will be no survivors dealing with the depression. And then also observe for and elicit information about physical or psychological injury and note associated stress-related symptoms such as numbness, headaches, tightness in chest, nausea, pounding heart, and so forth. We already get familiar to symptoms of anxieties. And also identify psychological responses like anger, shock, acute anxiety, confusion, and denial, which will making them slowing in recovery. And provide stress management and crisis intervention techniques to assist with extreme reaction of panic, hysteria by remaining calm and providing consistent reassurance. So this point 4 and 5, we will put the psychosocial aspect on it. So it will become one training particularly for this, but should be integrated in all competencies that the nurses will be prepared. So what kind of sustainable training model for nurses? Learning from what, when I was the president of Indonesian National Nurses Association, in 2004, 2005, we responded until 2006 to nurses of local Aceh. So what we did is that working together with WHO and Ministry of Health, we developed training. We have a module and then training for Master of National Trainer. So at the national level, because you know, as you see in the map, it's really spread out Indonesia from the east to the west and from west to the east, south to the, it's very, very large country. So, and then we have to identify and develop the training of local trainers. So wherever the impacted areas, and then we identify the nurses, and then meeting the criteria, and then we train, it will be trained by the master of trainer at the national level. So the local trainers will be well prepared, and finally they will be the one maybe at the beginning under supervision of MOT. So the TOT then will develop the training of providers to one who will be dealing with the people or the community. So I believe that no health without mental health. So integrated mental health in expected role of nurses in disaster is very important. So the nurses as an advocate, the nurses as community mobilizer, capacity builder, manager of health system and resources, primary care provider, which is focusing on promotion and prevention, but they can also dealing with the rescuer if it is required. And overall holistic care, physical, psychosocial, mental health integrator, health policy, behavior shapers, academic researcher, information manager, networker, and collaborator. So I think without nurses, there is no health. So it is really very important to integrate the mental health, psychosocial health in dealing with the people affected in disaster through the competent nurses who are prepared with the sustainable training. Thank you.
Thank you, Professor Yani. That's a great speech. And under your supervision and your leading, I bet the disaster risk management in Indonesia will have a prospect development. And also we are glad to listen and learn to you that you have such a systematic review and also have a globalized assessment of the nursing competence.
Thank you.
So I also invite invitation to all the participants. If you do have any comment or question or feedback to Professor Yani, please just write down, or you can start your text to Professor Yani or to all the audience. Later, we will share your comment and any question. We are welcome when we end all our 4 presenters. Thank you.
Thank you.
Now we are going to move to Professor Perni Susanti. Her talk is something relevant to Professor Yani just shared with us. The topic is required mental health related competence of Indonesian nurses in disaster of flooding, earthquake, and volcano eruption. I bet after 2 great professors sharing all the participants of today, we will learn a lot from 2 of them. Let's welcome Professor Perni.
Thank you, Prof. Lin. My voice is clear? Yeah?
Yes.
Okay,
perfect.
now I start to, thank you. Now I would like to start to share my PowerPoint. Can you see the PowerPoint on the screen? Thank you very much. Thank you. So I would like to start my presentation. First of all, I would like to say thank you for the invitation from the RIBAM. This is the second participation of myself in RIBAM. Hopefully, RIBAM will be successful more and more in the and of course now in the future. And right now, I would like to present. It's still connected with the presentation from Professor Akhiriani beforehand. So I would like to present about what is the mental health related competencies of Indonesian nurses in dealing or in facing disasters. And this is particularly based on our research that has been conducted in the last 2 years. Okay, perhaps Professor Yani has briefly explained about the condition of Indonesia, that we have 5 major islands in Indonesia, and we are the largest archipelago country, and we have more than 17,000 islands across the country, and we have lots of more than 500 local language and also religions. And because of this condition to another condition that is very familiar for Indonesia, Indonesia is known as the supermarket of disaster sources that make Indonesia has become a very a country with many disasters, like a meeting of 4 tectonic plates, 130 active volcanoes, and also we have more than 5,000 large and small rivers across this country, and 30% of these rivers pass through densely populated. Our significant background of our study that we would like to know what is the competencies of nurses required to face these disasters, particularly in 3 kind of disasters. They are often happened. First is earthquake, and the second is volcano or volcanic eruption, and the third is flood. So as mentioned by Prof. Yani before, I am as a member of a research team. We have conducted a study that has identified what are the survivors' needs from nurses before, during, and after the disaster. Publish a book of the standard of nursing practice for nurses, particularly in handling the disaster. And after this study, we go on with examination of the competency required by nurses, and also assess the need of training of nurses. So these studies has been conducted since last year, and we already have some results. And right now we are finishing, and we are analyzing our data. In this current presentation, I would like to present what are the mental health related competencies from the nurses under the study that are required by Indonesian nurses in dealing with the three most often disasters. So this is the methods conducted in three provinces. In Lombok, which is known as an area with earthquakes. Maybe you know, before in 2018, there was a huge earthquake and also followed with liquefaction, which is familiar with the volcanic eruption. Even right now, the volcanic volcanic mountain has been active several days, and also in Jakarta, the capital city of Indonesia, which is famous with of 100 participants. We use mixed methods, qualitative, and for the quantitative, we have 154 nurses, and we have developed an instrument. We have produced, and also we have interviewed nurses from those who have been surveyed to get data qualitatively. To get conclusion study. From the survey and interviews, it has a similar number of participants in survey and also in the interview, or who participated in this study. At least they are the nurses who have worked in strategic units when disaster strikes. So those who will work in the community centers, those who will work in hospital base, they were recruited as long as they have experience to handle survivors during the disaster events. That are the inclusion criteria. So this is the result of our study. As you see, the age of the nurse participants, in average, they were 34 years old. So it's in the yeah, and in for working experience, average, or they have worked 11 years, yeah, with the maximum working experience 35 years, and the minimum is 1 year. And most of the participants, from 144 nurses under the study, were women, which reached 60. And for the education, most of the participants were vocational nurses. Vocational nurses means they are graduated from diploma level, followed by professional nurse, which they have been graduated from undergraduate level. And as you see, yeah, they have there are various information about the experience in facing disaster. Yeah, mostly. It's both the same number, 51% and 49%. Those who never and ever experienced in facing disaster. This is very interesting. Even though from the criteria we have tried to recruit those nurses who have been deployed in units who should have been designed for disaster, but half of them said they never been experienced in facing disaster. And this is the experience in training related to disaster. As you see, 91%, about 132 participants said they've never been trained for mental health and psychosocial intervention for the disaster. This is also a very interesting finding, providing that my focus of presentation today, how the mental health related competencies can be identified from the participants. This is the source for information, mostly from the internet, and very small from the seminar. And this table would like to show you about how competent, how confident the participants have performed their roles. As you see, I give a pink color to show some competencies that are related to mental health. For number 1, number 2, number 3, number 5, number 8, and number 10, providing nursing care to grieving family and so on. You can see from the screen. And from the yellow part means the competencies that they are confident. They are confident. They are not confident perform. This is an interesting finding that I would like to share because for the yellow part, it seems that these nurses have been confident, have performed some mental health related competencies very well. But in qualitative, to some extent, this is not really corresponding. This is not really in line. I will show you later. Space or in the green for the and communication, the number is quite low. This means they acknowledge that they need more training, they need more more effort to be able to communicate. And this finding is accordance, or this finding is parallel with the qualitative investigation. I would like to go on with the result from qualitative interview. From the qualitative interview, we find that according to the participants, mental health care should be integrated with physical care. As you see from some quotes here, they say that we didn't assess more in psychological aspect, but certainly also a nurse from Lombok said, if there is a patient with a broken bone or every physical intervention needed in the field, besides doing that nursing care, we must overcome that psychological problem. So this is again, as I told you before, that is not synchronized with the data from the survey, which tell us the many nurse participants said that they are confidently have performed the integration of mental health and physical care. Another finding from the qualitative interview is that they recognize the importance of take care on mental health first and then others. And this means not only to the nurse themselves, but they also said we need to take care of our family's mental health first, and then we can take care of the others. As you can see from some quotes on my screen. And the other findings, we can identify what are the mental health related competencies needed by these nurses. The first is trauma healing. It is said mostly or many, from participants from flood disaster in Jakarta, and also counseling, giving education, so the survivors will not feel afraid or anxious even after the disaster. Yeah, and group intervention. Even though what I presented from Lombok, but from other areas of disaster, the group intervention, particularly play therapy for children, are very needed to be equipped for nurses. Another competencies is there must be intervention to involve family. This is very apparent, or it reveals from many quotes from the three areas of disaster or three areas of studies. So they said there must be patient's family around. And also we gather the patient after the disaster with family to decide how to deal with trauma. This emphasize how to the approach. I mean, the approach to give intervention to the individual survivor in Indonesian context, and I believe it's also in Asian context. Mostly, we have to include or involve the family as well. And the last finding from the qualitative interview, it is very strong that the nurses need communications to be improved and also needs to be included in the future training. The communication here means how we really can communicate. We don't have to be sympathized, but we really need to communicate in a good way, effective communication. And then we have to touch the patient heart first. So this is two times it mentioned by participants. Touching his heart is very important. And then she said, but what happened if we go to the patient, we go to the survivor, but we are not unfriendly to them? It is meaningless to them. And last one, besides the communication individually for the survivors, they also suggest for communication more effectively across sectors. In conclusion, I would like to say the study has indicated that the nurse participants have been confident in delivering some mental health related competencies. First, providing nursing care to grieving family, integrating mental health and physical nursing care, and facilitate family function, and providing care to service providers. These are particularly obtained from survey study. However, to some extent, these findings are not in line with the interviews, particularly related to the integration of mental health and physical nursing care, and also about the providing care to the service providers. This maybe can explain why we need to mix study, not only rely on survey, but from the qualitative, we can dig information more richer or more deeply about what are needed by these nurses. And from the interview, we can also know there are four main themes revealed: that mental health care should be integrated, the importance of to prioritize nurses and their families' mental health, and also identify some required mental health, and also the nurse communication that are needed for supporting survivors. In addition, from the conclusion, I would like to emphasize as well, there is an outcome that is in line result from survey to qualitative, particularly in the need of communication skills. At the end, These results are expected to be the basis for developing a training module and a program for disaster risk management in Indonesia, especially how to include mental health related competencies in the training that we are doing this year. This is my presentation. I can end my presentation right now, Professor Lin, and also the other. I would like to say thank you for your attention.
Thank you. Thank you for you two great presentation from University of Indonesia. Those two have a very related issue about the risk management for psychiatric nursing. And also for two presenters for your attention, because some of our participants has write down some of their comment about this topic. So if you open the chatting box, you may have chance to look at. First is to mention about how we taking care, put the focus on nurse and how you to solve the problem. And then comes a question that is concerned about nurse are provider at hospital and healthcare, dealing with the infected individual and care of the family. So how about Professor Yani or Hernie, you can answer about this question. And then another one will be moved down is mobilize resources needed by nurse. Some of the meal, vitamin and APD has been commented.
Sudah saya kirim. Sudah masuk ya. Yang direkam itu tadi.
And last question is about the short-term intervention is stress management using different simple technique. This is a comment. Maybe you two can think of those comment or feedback from our audience. And we are, while you two get ready for those comments, we are going to move the third number 4 presenter.
Yeah, maybe Prof. Yani would like.
Yes, actually, I give my written comments on that answer to answer some questions concerning nurses.
Thank you.
Yeah,
so
it is written there. Yeah. Actually, what you read is what I answered then.
Yes, and also great thanks to our audience. We have a multiple way to exchange our opinion.
Sure.
Sure. And how about Hernie? Do you want to provide some?
Mama nggak connected ke
or you
komputer audio.
Sorry.
For me from the chat.
Yes.
Yeah, I would like to comment about the. I would like to comment about the previous question. Whether with psychosocial therapy that effective for the survivors with PTSD. Well, according to our participants in our study, what they do for the post.
Maybe we are losing her
Not
now.
only them. Hello?
Yes.
Can you hear my voice now?
Yes, now
Okay.
it's clear.
Okay, thank you, Prof. Lin. Yeah, I would like to respond the previous question from this one is from Suntari Srikosai, yeah, regarding the psychosocial therapy that effective for survivors with PTSD. From some participants in our study believe that intervention such as particularly the group therapy for children like a play therapy, the nurses or other health people doing make activities with these children are believed to be more effective. But unfortunately, there's also evidence from the participant, yeah, said that they really need to be equipped with this kind of intervention because what they see on the field, it is delivered or it has been delivered by what is it? What is LSM, Prof. Yani? I forget. LSM is
A family
like
psychoeducation.
non-health professional. Yeah,
Oh,
from
non-health professional.
yeah, from non-health professionals.
Non-health
Yeah.
professional.
So yeah, from non-health professionals. So they said that we should be able to do that. We are health professionals, but we don't know to start. We don't know how to next training to be designed be items. They should be contents about how to help these children, like what the others do. So this is a very what is it like a call, important call from the for the researchers and also for all Indonesian nurses who take part of this area. Uh, And also, I would like to respond the specific question about questionnaires. Can you suggest some questionnaires to assess mental problems related to disaster? For this current study, as I mentioned, we have developed questionnaire specific to identify the training needs. So we develop for ourselves. But for to assess the mental health problem, we suggest a questionnaire like SRQ. What is SRQ stands for? Is and also DAS, yeah. Because we have also conducted a study, Prof. Lin. We have conducted a large study, survey study, for 2,000 and more, almost 2,200 nurses across Indonesia in responding to COVID related to the mental health status and also the stigma experienced by these nurses. The nurses under the study are nurses who are delivering services to the COVID patients in hospital targeted for COVID. If I can share a little bit about the result of our survey for these 2,200 nurses, it is quite a pity because these nurses felt stigma. They feel stigmatized by the community, by the people, even though in quote, they have sacrificed many things, like they being left, like in the neighbors avoid them, something like that. Even there are small number of nurses being threatened to be divorced by their spouse because of their helping COVID patients. In terms of mental health state, like 2 months ago in May, yeah, in May or June. So this is still relevant. Most of the participants most of the nurses felt now. Hopefully, I can report or I can make a full writing about this result, because this is all about how we can others help ourselves.
Thank you for Hernie and Yani
If
professors sharing.
is there still have a time for me? Just 1 minute
Yes,
to
please.
continue? Okay. So we explored, because of the nurses under stressful situation of stigmatization, then we follow how is the support system from the family. So from 199 a family of nurses, and they are family resilience with from 1 to 4 is 3.08. So it means that they are resilience enough to cope with the what is undergoing having the family members who are a nurse. And the second one, the coping strategies being used. So they use more spiritual support. And the second one is mobilizing family resources. But the less use that use the coping strategy of asking a social support. So means that asking from the neighborhood and others, social environment. So it means that they're only trying to help themselves within the family. I think it is related to stigmatizations. If it is known as family members is health professionals. This is to add to 199's family of the nurses responded. Thank you.
Thank you, Professor Yani. I think we are looking forward to read your published paper, Hernie. Sooner, I guess, we are in terms of our sharing and conversation, we have a chance to read more from both of you.
Yeah.
Because the time limit. Now I'm going to move to the presenter. For all the audience, because I make adjustment for Professor Yunis Setiwati from Surabaya, Indonesia, University
UNER, Erlangga.
Erlangga, sorry, University Erlangga. Her topic is early detection of learning disorder on elementary school in Surabaya, Indonesia. I make adjustment because this is a group of 3 from Indonesia, and we have a cultural sharing from different perspectives, from disaster management to adolescent care. So, Professor Eunice, are you ready? Sorry for this adjustment.
Yeah.
Thank you. Time is yours.
Good afternoon, Prof. Meling. Thank you. Can you hear me? Voice clear? Good afternoon.
Yes.
Yes. Okay, it's I will share my
Go ahead. It's fine. Your voice is good.
yeah. Yeah.
Yes, Eunice, it's fine. You may go ahead.
Thank you. Good afternoon.
Good afternoon.
My name is Yunia Siawati. I'm child psychiatrist. from Universitas Erlangga, Indonesia. First, I say thank you for the committee who gave me opportunity to join in the symposium, and also thank you to Prof. Mailing as moderator. And thank you for nice presentation from Prof. Yani and Prof. It's absolutely interesting for me, this unique moment. Yeah. Okay, I want to present my activity in Surabaya, Indonesia. I want to present about early detection of learning disorder on elementary school in Surabaya, Indonesia, bridging and collaborating across ASEAN countries for improving children mental health in Indonesia. Goal of my activity is to make a better generation in the future. Outline of my presentation is background, goal, method, result, and conclusion. Background, as far as we know, childhood learning disorder are a major problem in developing countries, especially in Indonesia. Many elementary schools are taken to the clinic because of learning disorders and can impact emotional disorder and can impact a burden in family. Prevalence of learning disorder in the births range between 6 until 16%. Learning disorder and mental disorder of children need serious attention because it has an impact on the development of adolescents and adults. Day in and day out, the most common childhood mental emotional disorder in Dr. Stomo General Hospital Surabaya that I work here is attention deficit hyperactivity disorder. The second, autism spectrum disorder. In the third, depression, or mental emotional disorder of preschool children, and the last is learning disorder. Based on this data, we help on a community education to early detection at the primary health care with support of the research unit and community service at Universitas Erlangga, Surabaya. My activity in multi-year research is in 2013 we uh, we found that for about 3.6% early childhood have a risk of suffering autism spectrum disorder, and in the next year, when we screening ADHD, the result is 6.7% of primary school children have a risk of suffering ADHD. And then in the next year, on 2015, there are 7.8% of primary school children have a risk of suffering depression. And the last, in the 2017, there are 13.7% of early childhood have a risk suffering mental emotional disorder. Based on this condition, we collaborate with psychologists with the support of Surabaya City Health Office in Surabaya for detection learning disorder in Surabaya. Roadmap of psychiatric activities with government support for the next 5 years. We have early detection of learning disorder in elementary school or in Indonesia era Madrasah Ibtidaiyah, which the goal is for about 30% children can be screening with with about learning disorder, and the last from 2018, and the last on 2022, we can early detect learning disorder in elementary school or madrasah ibtidaiyah increase for about 50%. Okay, next. Next of our activity as child psychiatrist team is to find out data of learning disorder in elementary school students in Surabaya. And then we conduct integrated management with parent, teacher, psychologists, psychiatrists, and stakeholders. What we have done, child psychiatrist, Dr. Sutomo General Hospital, with the support of Surabaya City Health Department, in collaboration with psychologists at the primary health care and teachers in primary school in Surabaya, conduct periodic education in elementary school, and then provide guidance on learning disabilities screening that is filled by parents. After that, child psychiatrists compile and distribute pocket book to get teacher and parents in participating in the education and questionnaire filling activity. Okay, so let me show there is parenting education in elementary school in Surabaya and interested in the screening. We have screening for teacher and parent for disorder or for learning disorder. And then after that we make a parent consultation and teacher consultation in madrasah ibtidaiyah and in elementary school. We make a mental health book for guidance our activity to improve the knowledge of parents and community about emotional disorder in children. Also divide leaflet on outpatient department and the community for improve the knowledge about mental emotional disorder. And after that we make a journal and publish journal about children mental health journal about parent and environment can impact into the mental emotional problem in their children. And there is collaboration we as psychiatrist team with public health doctor in international congress that we present our research. Yeah. There is some method in our activity for screening learning disorder is public health office coordinate with the education office of Surabaya City, determine 33 elementary school in Surabaya with the problem of learning disabilities. And then child psychiatrist team in Dr. Sutomo General Hospital conduct counseling about learning disability and supervise CLDQR that fell in by parents. And then child psychiatrists coordinate with teachers and psychologists in primary health care to consult with parents of children whose children have learning disorder. And when we meet, psychologists make a referral to the Child and Adolescent Division and Department of Psychiatry in Dr. Stomori's General Hospital when they found problem with their mental and emotional disorders. There are screening results in Surabaya on 2019. Only 11 children on normal limit, and we referred 596 moderate learning disorder and 129 severe learning disorder from primary care to cell division General Hospital Dr. Sutomo for continuously treatment. And then we make integrated treatment involve parent, teacher, psychologist. The conclusion of our activity is early detection of learning disorders is beneficial in increasing cross-sectoral collaboration in the fields of child and adolescent psychiatry. The opportunities for child and adolescent psychiatry in Indonesia. Currently, in Indonesia, the number of child psychiatrists is only for about 50 people. So, the presence of center in child and adolescent psychiatric education can increase the number of child and adolescent psychiatrists. And then we can make cross-sectoral collaboration involving government, community, and health team in the field of child and adolescent psychiatry for helping early detection and management of learning disorder, mental disorder of children and adolescents. The future program in child and adolescent psychiatry in Indonesia is cross-sectoral collaboration. It's needed in Indonesia and ASEAN by involving child mental health teams, communities, and government support. Because the program for early detection of learning disorder and emotional mental disorder of children in Surabaya can bridge the children mental health research in Indonesia and ASEAN. That's all my presentation. Thank you.
Thank you, Dr. Eunice.
Yeah.
This
Thank
is
you.
a new topic for me, and I can learn more about the learning disability. And also because the time limit, I want to open the chance to all the audience. Maybe you can type or text your question and comment to Dr. Eunice just now. And later we will go back to your answer or your feedback to our audience. How is it? And in terms of the opinion exchange moment, the number 4 presenter, Dr. Sudan, she's still on the meeting, but she already get some of the recorded material for all of us. I think we got a chance to have time and we can learn some, maybe I can set for 10 minutes for his recorded material for all our audience. If you do agree, because our session have a little bit behind our schedule. So I'm going to last it to 2:35. Is that okay for all of you to stay with me? Thank you. If so, Lucy, can you help me to load on Dr. Sudan's recorded just now. And meantime, I'm invite all our audience. Maybe you can text some of your comment to Dr. Eunice. As I'm just right now is about think of the rate or the prevalence rate of the learning disability of your population. How's the difference between your research finding and other researchers? Because you have a very a big number of moderate learning disability in your data set. That's my first question. And my number two is, what's the next step when you notice in your population, the young adult, the young adolescent, they do have a higher learning disability problem in the far future? How you are going to fix this problem? That's my thinking about your presentation. Okay, so we are waiting for your answer. And now I'm going to jump to the number 4 from Dr. Sudan. Dr. Sudan is a professor from University of Colombo in Sri Lanka. It's hard to have such exchange opportunities in our event. So how about we start in a couple minutes? So Lucy, would you please turn on?
Hello, good afternoon, ladies and gentlemen. I am Dr. Sudat Varnakula Surya, a senior lecturer in nursing, Dean Faculty of Nursing, Sri Lanka, University of Colombo. I think it is great honor and privilege for me to address this very important research symposium organized by REBAM, the National King Kung University, Thailand, selecting very important topic, bridging Asian mental health and psychiatry. This is very interesting and also timely important topic. This research and education center of this university, I think, have made wonderful effort to organize this second conference of research and education. Therefore, I would like to thank the Professor Lucy, who coordinated with me regarding this program, and also I would like to thank our nursing colleague who is a PhD candidate in National King Kung University, Mrs. Sriyani Padmalata. She was the person gave me this contact and organized this thing. I met Professor Lucy and also our good friend Sriyani Padmalata yesterday through online communication. Therefore, I would like to thank both of you again for giving this opportunity. That is great honor and privilege. Right, I am from University of Colombo. We have only single faculty of nursing in Sri Lanka, that is Colombo University Faculty of Nursing. I am the at the moment I am the Dean of the Faculty of Nursing, and I am also I was the former head of the Department of Clinical Nursing. Professionally, I am a psychiatric nurse, registered psychiatric nurse, and also I have 7 years working experience in psychiatric field, and also I have 15 years experience in teaching psychiatric nursing for undergraduates, and also I have 2 years experience in developing psychiatric nursing curriculum and delivering psychiatric nursing education in Republic of Seychelles under the WHO project. Right, Sri Lanka is very small island in the Indian Ocean I think you can see the distance between Taiwan and Sri Lanka. This yellow line indicate in the map that our distance. We always had collaboration with Thailand. These Thailand people are familiar to Sri Lankan because most of Sri Lankan and Sri Lankan go to Thailand for different purposes, educational purposes, and also business purposes. Since time immemorial, the collaboration or a friendship between Thailand and Sri Lanka existed. Right. As I mentioned, this small island is a very beautiful island. There are a number of beautiful and picturesque scenarios in Sri Lanka. This is we are having large number of beautiful sceneries, and actually that is one of the UNESCO heritage selected for this some of the special areas in Sri Lanka. Today my topic is current trends and issues in mental health and psychiatric nursing care in relation to Sri Lankan context. Right. This island has been divided into 9 provinces for administrative purposes, but you can see in diagram the right side there are large number of mental health services and institutions where mental health services are provided to Sri Lankan community. As a country, Sri Lanka has more than 21 million population, nearly 22 million population, and also there is a growing trend of the population. This growing trend always indicate that some kind of mental health problem in the country, because we have observed that the large number of patients with dementia and depression increasing during the past. Right. Population wise, we have 3 ethnicities: Sinhala, Tamil, Muslim, and Burgher. The majority is Sinhalese. Right. What are the problems related to mental health? There are some factors, major factors contributed to mental health problems in Sri Lanka during the past. I just mentioned here. Natural disasters frequently occur, especially flood and landslides, and also survivors or the victims always experience this mental health related problems. And also you know that the tsunami in 2004 badly hit our nation, and large number of people died, and there are a large number of people surviving, but they have a lot of mental health problems, especially post-traumatic stress disorders and depression and so many other things. Again, there's a great trend in increasing substance abuse by different the age groups, especially young people, unemployed people, and that is a big menace in the country that lead to mental health problem. As I mentioned, there is a growing trend of aging population. Parallel to that, there are mental health problems gradually arising. And also psychosocial stresses always there everywhere. It is common to Sri Lanka also. So psychological stress, work stresses, and this big competition in this fast moving world always contribute to this mental health issue. As you all know, there was a civil war lasted more than 30 years that ended in 2009-10, but until recently we experienced that impact of civil war for more than 30 years. Large number of victims are there, the families, those who have loved one lost, and also properties lost, and sufferers are still there. These people have large number of mental health problems. And also there is a common trend that nowadays increasing road traffic accidents every part of the country. Nearly 8 people die every day with the road traffic accident, and also large number of people with disabilities and victims in families have these mental health problems. As I mentioned earlier, depression is increasing, there's a growing trend, and also dementia is another growing trend in our country according to the health statistics. Right. In a country, mental health is always um, mm, the plan and organized according to health policy. In Sri Lanka, there is a mental health policy that has been designed and organized between 2005 to 15 the target, but as I mentioned earlier, after Asian tsunami, the health policy makers has wanted to have immediate policy to deal with the mental health problem in the country. Until then, they did not pay special attention to this area because they realized that after the tsunami, they want to have this kind of policy. This policy given rise to various new plan and programs to develop mental health in the country. Uh, the vision of this mental health policy in Sri Lanka, it's a comprehensive and community-based services. It is to be established which will optimize the mental health of Sri Lankan people. And also, this is accessible and affordable services will promote the mental well-being of the community at large. The ensure the dignity and rights of the citizens and especially those in vulnerable and disadvantageous circumstances. So it is very clear the vision of the mental health policy in Sri Lanka that is targeting all the citizens and also ensuring dignity and their human rights and also mainly focusing on vulnerable and disadvantageous circumstances. So this is the policy driven to mental health provision in Sri Lanka. The national mental health policy has two objectives: to be an essential instrument. It is considered as an essential instrument to ensure clarity of vision and purpose in improvement of the citizens of Sri Lanka, to treat mental disorders in an efficient and holistic manner. Those are the objectives of the policy. Right. There are some main principles identified in this policy, mainly to provide mental health services at primary, secondary, and tertiary levels. Because previously, the mental health services were available only in tertiary level in the large teaching hospital and the mental health institution. Now, target is changed. You have to address this area primary and secondary level to provide services of good quality where and when they are needed. That is what other next principle, focusing the quality of good quality of the services. Third one, to provide services that will organize at community level with community, family and consumer participation. Today focus is to community focused, family focused intervention and participate with the participation of the consumers. The next one, to ensure mental health services will be linked to other sectors. That mean that intersectoral collaboration, coordination is required to provide proper mental health care. You cannot provide mental health care in isolation. To ensure mental health services will be culturally appropriate and evidence-based. Today, in the health sector, there's a sharper focus on evidence-based care. Therefore, and also culturally appropriate. Whatever the new intervention is not useful if you are not culturally sensitive. Therefore, this principle is highly emphasized the cultural appropriate nursing, and also protect the human rights. As you all know, in the mental health sector, with the people with mental disease condition, large number of people are affected with their human right violations due to various reasons. There are strong stigma, discrimination, prejudices against mentally ill people, especially in Asian countries. So this is something highly focuses under these principles to protect their human rights. Right. This mental health policy, especially focusing during 10 years period, 2005 to 15, but new policy is being progress at the moment. Call for implementation of comprehensive community-based decentralized service structure. As I mentioned, there was a service-oriented programs, but mainly focusing on reputed hospital and teaching hospital and tertiary level. Now the structure is focused on other areas. The main objectives were to provide mental health services of good quality, primary, secondary and tertiary level, as I mentioned earlier, to ensure the active involvement of community and family and service users. That mean family oriented, community oriented and service user oriented programs are designed to make mental health services culturally appropriate and evidence-based, and also protect the human rights. Those things I have again repeated. And also significant improvement have been made and new cadres have been created for providing mental health care, and there are some advantages for nursing profession after implementing this mental health policy in Sri Lanka. Now I will focus your attention on main healthcare resources that has been organized and planned. Train medical officer for mental health. That is new thing after this mental health policy, because previously you have consultant psychiatrists and people, the medical people who are working at the tertiary level mental health care units and hospital, only the resource people for providing health care. Now each and every district, as I mentioned, there are 9 provinces and 20 districts in Sri Lanka. Each district at least you have one trained medical officer with mental health qualification. And also new cadre creation, it was done after this mental health policy. Now in Sri Lanka there is a health nursing profession called community psychiatric nurse that has been trained for 6-month period in addition to their basic training, and they are working in the community in collaboration with all the mental health institution. And also there's a new volunteer groups has been identified currently. They are using these volunteers, total number of 4,670. Each and every district, large number of volunteers are providing with short training and preparatory programs. They got short training and preparatory program followed. Thereafter they are working, and there are some national and international, the local and foreign people, young generation, they have participated these voluntary programs in mental health. Right. When you come to the trends, the policy which was the main turning point after the tsunami situation. Now, as I mentioned, there was a 10-year policy first established, the second one. Then now it is in progress. They are targeting another 9 years, 2017 to 2026. That is the new policy. It is still in progress with new amendments. And also this trend is sharper focused on not only the medical model but to the biopsychosocial model. As all psychiatric nurses know that we are not mainly depend on medical model and medical treatment. There are various other alternative therapies for psychiatric care psychiatric patients. So nurses always they are following their degree programs or diploma program by linking with this holistic approach biopsychosocial model. We always adhere to that. But previously the medical people they totally limited to this medical model. Nowadays this focus has been changed. Now we are focusing biopsychosocial. That means other therapeutic approach also accept and also giving opportunities for other healthcare providers, the alternative therapists to involve in mental health care. That is very good positive change in the mental health care sector in Sri Lanka. Training the mental health care workforce is continuing, but is still not consistently done the training. But there is a initiative has been taken. That mean some programs are there, but not frequently training, but from time to time they train the program. That is also needs some consistent training for mental health professionals. That is one of the trend even we can take as positive thing, because previously there was no. Involving the community in mental health care, that is highly emphasized, and also all the mental health care sectors now involving this community people in mental health care, that is respecting their dignity in the area of healthcare and decision making. Right. As I mentioned, large number of health care workers, especially volunteer organization present here. 80 community volunteers organizations, they are island-wide. The large number of community healthcare, mental health care organizations, NGOs are there in all 25 administrative districts. Now, as I mentioned previously, we had 22 districts. Now we have created 3 more districts, but everywhere this volunteer community mental health workers are working. That means they are providing great service to the community by providing mental health. And also mental health care workforce in Sri Lanka, if I summarize the thing, consultant psychiatrists will be the technical leader in the district mental health care team, and also medical officer mental health, newly created cadre during past decades, and also nurse in the hospital play a major role, those who have got short training but in mental health psychiatric units, and also longer term development of new cadre of psychiatric nurses. That is the main requirement I mentioned in the community as well as in the hospital. That is the plan, and inconsistently carrying out this thing. Psychiatric social worker, they have been working in the mental health care sectors, but that category also is getting expanded, and that now the degree holders with social services or sociology related degrees, they are employed in as psychiatric social workers in the mental health sector. And also as usual, the occupational therapist, mental health, and also other new category is in the agenda, that is clinical psychologist. That is most important category in the mental health care team. In some countries, this clinical psychologist is always in the mental health care team, but previously we didn't have this clinical psychologist in Sri Lanka. But nowadays there are a lot of degree programs to develop clinical psychologists, that those people are going to be employed in mental health care sectors, and especially in psychiatric hospitals and units. Right. Whatever the mental health I talk, the positive aspect, there are some unfinished agenda for mental health well-being in Sri Lanka. Compared with physical illnesses, there is a delay in recognizing mental illnesses. This delay occurs at both patients and family level, because they're reluctant to come to the mental health institutions, mental health services, and also the medical professionals delays are there. And also considerable delay in seeking effective treatment. Delay because there are various myths and misunderstanding about the disease condition. Therefore, they follow that kind of myths that is common in Asian region. There are a lot of myths related to mental health. That delay always leading the person to chronic state of the mental illness because of these delays. And also, as I mentioned, these practices add to delay in treating individual with mental illnesses. Whatever the delay after the identifying the disease condition or recognizing some mental illness, when you are getting delay all the time to come to the proper treatment, that leading to delay in treatment, delay in prognosis, or that means delay in curing or managing the patients, and ultimately leading to chronic status. Not having consistent training for psychiatric nursing, that is also one area, because as I mentioned, they have started the 6-month psychiatric nursing training, but is it not consistently done? That is one of the area we have to focus on. Not having qualified psychiatric nursing academics and trainers, that is also we have to have. Even there are no special nursing training for psychiatric nursing professionals. Therefore, at least the government should take measures to train our psychiatric the nurse educators in that area, at least by sending to the countries where good mental health trainings or the education is there. But still we need to address this issue. And also, if you need to proper training for psychiatric nurses, before that you need to have qualified psychiatric academics or the trainers in the field. That is one of the area we have to write. Now, up to now, I just discussed about our mental health system and area, the government actions, policy, and all the things related to mental health. Now, I mainly focused on my presentation to the psychiatric nursing. Yes, everybody knows that the founder of modern nursing, Florence Nightingale, made an attempt to meet the needs of the psychiatric patient with proper hygiene, better food, and also light and ventilation. According to her theory of that mean she according to Nightingale's theory with regard to environment and hygiene and all the things, she especially focused on this psychiatric patient many years before, and also deal with these aggressive patients, violent patients. They need other facilities other than the chemical psychiatric the drugs and other stress training procedures. With that knowledge, if I talk about the psychiatric nursing, as a person who have worked in that field and also experienced, I have visited various countries, but there's a great demand for this profession, and also this is very challenging profession according to my experience. And also, psychiatric nurses are expert in crisis intervention, mental health assessment, medication and therapy, and also patient assistance. That is something identified by the American Nurses Association as well. Psychiatric nurses work closely with the patients to help them manage their mental illnesses and live productive, fulfilling lives. That is why we need to have trained, qualified psychiatric nurses. But if you look at this profession in different countries, role differs and it is context bound. According to the context, their role has been decided. That means whatever the qualification you have, but role is totally dependent on the context where you are attached to. To be a psychiatric nurse, you need something more than qualification. That is what I need to highlight. Because according to the definition of psychiatric nursing, it is very clear say that you need to fulfill or strengthen two areas. Those are you have to have clear understanding about all the theories of human behavior and all the theories related to human behavior changes. That means psychology. That means your knowledge should be very strong in psychological theories and behavior theories related human being. That is the science of psychiatric nursing. Other important aspect is your self. You have to make yourself strong. You have to have a bold personality, and also you have to have a very good therapeutic communication skills. Not only that, you need to have some kind of interpersonal skills, and also very good coping skills and critical thinking, because you have a critical decision maker in the psychiatric field of mental health. At such situation, you need to use that skills. Not only that, you need to have situational decision making abilities in the psychiatric care. That means, in according to the definition of psychiatric nursing, offering self is very important. Offering self, and that is used as an art. Then there are two things in psychiatric nursing. You are using all the theories of psychology, behavioral sciences as the science, as well as you are using yourself as an art. That means this combination comes as psychiatric nurse. But thing is, most of the countries, especially in Asian region, these two things combination is not much level of required level, because these trainings are mainly focused on medical model most of the time, but therapeutic development of the person in a therapeutic skill, communication skills, that area lacking in many training programs, because psychiatric nurse gain knowledge in theories and the drugs and the treatment and symptoms, but their interpersonal relationship with regard to therapeutic communication and techniques related to therapeutic communication, those are the areas we need to focus when you are training psychiatric nurses. Right. I will come to the qualification that also differ from country to country, place to place. I have highlighted in our context. Normally, general nurses get only 5 weeks training in addition to the theory part of their training programs, diploma level. But 6 months training for diploma in psychiatric training, those who are following the 6-month diploma, you can work in psychiatric units as well as in the community psychiatric field. And also the different two things are there. They are especially training psychiatric nurses for the community, 6 months training community, and your affiliation and training, all the things done in community, and you are following your intern period also in the community. And also some developed countries, especially Australia and USA and most developed countries, they have bachelor degree even for psychiatric nurses, and master level education, master degree in psychiatry. Then you can be a specialist, specialized forensic. If you gain more knowledge in forensic and law and other legal aspect related nursing knowledge, you can be a specialist in forensic psychiatric nursing. But psychiatric nurse practitioners are there in well-developed countries with all the experience and knowledge. They can independently work in the community and mental health sector. That is something lacking in Asian countries, but we have to focus on that in future. Right. As I mentioned earlier, so role of the psychiatric nurse is totally depend on various factors: philosophy, mission, values, goals of the treatment setting. Depend on their philosophy, how they are providing care, what are the programs they have, and accordingly the role of psychiatric nurse has to be adapted. Number of clinical staff available and services they are available to provide services. That is one of the major concern. Most of the countries in African region, the people in special skills and knowledge are very rare. You cannot find psychiatrists in that area. Miles and miles, thousands miles you have to go to find a psychiatrician. Therefore, major role played by African region. Psychiatric nurses with short time training, they are doing everything for the patients, because They are the people accessible to the patients in thousands miles away from the main hospital. Therefore, the psychiatric nurse, the role is bigger and have big responsibility in African region, in many African region, countries in African region. And also organizational structure and reporting relationship in the setting. That is also one determinant of determine the role of psychiatric nurse. Consensus reached by the healthcare provider. There are some consensus, you come to a conclusion that I will do this part, you will do this part. That kind of communication, especially in Sri Lanka, there are, as I mentioned, community psychiatric nurse have that communication between hospital institute-based psychiatrist and community-based psychiatric nurse. They come to conclusion what are the things I should do, what are the responsibilities I have, and how to follow up things done, and all the things come under according to the consensus made by the two parties. Resources and revenues available to the offset cost of care needed and provided. That is another problem, as I mentioned earlier. In African region, very big scarcity of resources, and they have lack of resources, and therefore then you cannot provide proper psychiatric nursing care, and you have very few people with training. Therefore, that is also determinant factors to determine the role in that sectors. People have more roles and responsibilities in the mental health field. Presence of strong nursing leadership and mentorship, that is also one determinant to define the role. If you are a trained psychiatric nurse with good leadership, you can determine the role of the psychiatric nurse, because sometimes there are some poorly defined roles and responsibilities always leading to lose the nurse's dignity and their reputation. Therefore, if you are a strong leader in that sector, you can look after the nurse's role, and this thing, that is also one determinant. We should know trends in our sector. Also, we experience that problem. Areas where you don't have good leadership in nursing have less responsibilities and less opportunities for psychiatric nurses. Right. As I mentioned, for the first time in Sri Lanka, we developed and established community psychiatric nurse after the first national mental health policy. This person always involved in different care activities, supervise treatment adherence. You go to the community and follow this thing. Home-based, that means you are visiting each and every patient according to your area. Administer treatment, include depot injections for patients. As per instructed by the medical staff, you are having some communication with the consultant psychiatrist. Provide mental health education to patients and the family members, and also act as link to improve referrals. They are playing major roles in the community. That is, I mentioned that in Sri Lanka, this is gradually improving, but some areas still you have not established this position, but some urban areas with, which is related to the National Institute of Mental Health, that position is now established and providing wonderful service to the community in Sri Lanka. I have when I have gone through one African study, because that area is very important for us, because as I mentioned, African region psychiatric mental health nurses playing a great role, but they have carried out a study, and they have identified some major concern about unsafe environment with lack of resources. That is a major problem for them. Work dissatisfactions and negative feelings for the psychiatric nurses, and also need specific training for the management of patients. Those are the concerns in people in African region. This is a systematic review paper, and therefore collectively they have collected all the research published in that area. What are the major issues? Ultimately, as theme, they have developed in a qualitative study, organization and management related issues, perception of professional safety and insecurity, those are the areas of concern, emotional experience of the healthcare providers, especially nurses, relationship with the person, patients, there is something, again they have focused and they have identified as theme, recommendation for improvement. Those are the major themes derived from that study, but major concern they have raised, I have highlighted in 3 points: unsafe environment, work dissatisfactions and negative feelings, as well as need specific training. But some of these concerns are there even in Sri Lankan context, but this is a very pathetic situation in African region, because very rarely you can find the health professional with mental health and psychiatric training. Right. As I mentioned at the beginning, nursing, psychiatric nursing is challenging profession due to various reasons. But these are the challenges identified by the people in this research study. Sorry. I will show you this small video clip with regard to nursing. Right. With that note, I would like to mention here, I would like to thank again the National King Kong University professor who contacted me, actually the Professor Lucy, and also my good friend Sriani Padmalata. I think I'm trying to join your program in correct time, but I don't know. Yesterday we tested this connectivity issue were there at last moment. I couldn't hear anything, but if you have any questions at that time, I will try to answer. But thank you very much for giving this opportunity. So I would like to thank National King Kong University the regarding this, giving me this opportunity for conducting this session with regard to nursing, psychiatric nursing in Sri Lanka, bridging Asian mental health and psychiatry. This is one important session. I hope you got some picture regarding the Sri Lankan context, and thank you so much again for giving this opportunity. Thank you.
Yes, understand. So before we close our session of today, I want particular appreciate all our presenter, Dr. Eunice, Professor Yani, Hernie. Those are my close friend and also a great professor that I met in Jakarta. And I do appreciate our friendships before, maybe 2 or 3 years ago. As you share, I'm taking this advantage that we can learn more from you as the expert in managing disaster, and also develop some of the nursing standard care. I'm looking forward we can have chance to meet in face-to-face and also in person. Thank you for all the participants to join with us with this great chance to learn this issue for all of us. And think of the COVID-19, we are so lucky still staying healthy, still pretty, still want to generate our product in the far future. So we are looking for the promising future and looking forward to meet you all.
Yes. Yes, Prof. Lin. We hope next year we can meet up and there will be the third
Rebound.
Yes.
one again.
Yes. When Dr. Chen show off, yes, we are hoping we can have the chance and we can fighting successfully with COVID-19, and then we will see you in Tainan, Taiwan, and CKU again.
Yes. Okay, thank you as well,
Really wish
Professor
to see
Willie
you.
Chang.
Thank you,
It's very
Prolin.
good to
Thank
see
you, Prof.
you.
Willie Sang. Thank you so much.
Yeah.
Thank you,
Thank you very
everybody
much to
standing.
join us online. Thank you very much.
Yeah.
Stay healthier.
Yes. Thank you.
Okay, let's take a picture. Can we take a picture now?
Okay, take a picture. Everybody show off your face. turn on your screen and show off on the screen.
But there is still a pictures
On the screen, we
on
have
the
the
screen.
first band
想要在这上面，对对
in
对。
front of. Okay, so we have the chance and meet at first reband.
Okay.
不用共用，不用共用。对。
It's
Okay.
also a challenge for our technology support, right, Dr. Chen?
Yes, we are also trying to familiarize
We
all
are turn virtual into real encounter.
As long as you don't touch leaf.
Right. Right. Children,
可
it's
以让
like
大家看到
Okay.
it's like
没有，现在我只看到美国。
我也不知道为什么我没有出现，但是我自己放了一个，没关系。It's also a challenge as well, COVID-19.
Yeah, that's actually a huge challenge.
Right.
Yeah, we keep trying. So, 那个林老师，你说你那边
对，我没有出现在荧幕，但是我自己荧幕是有 turn on 的，但不知道为什么没有出现在 participant 这个荧幕上。
因为你看到的就是
我自己
昨天以外的人这样子。
那就只有这几只了，算了吧。
其实这样也蛮。
Honey, I thought this is really challenging.
就是我拍照，然后传上去这样子。
Okay, we have an additional extra support from our technician.
对对对。We are now trying to take a picture from our side. 不是你过来这边。
Okay.
Please hold for a moment. We are now trying to take a picture from our side. Later we'll send to all of you.
All right, okay.
Okay. Everybody, if you want to show off your face, please join with us.
Just show your face in front of the monitor. Then we will give you this picture.
Right. Everybody just turn on your screen and we can have a produce, like a production.
Okay, we have already taken one. There's another one.
And Dr. Eunice?
Smile.
Eunice?
Okay, we'll send that to you very soon.
Thank you, Dr. Zen, for your kindness.
Thank you.
And for my friends that say
Thank you,
goodbye.
Bye.
Shall we stop now?
See you soon. Yes.
Yeah.
Bye.
Province.
Yes.
Yes. So
Bye.
hope to see you one day.
Yes. Thank you.
Keep healthy.
Yes. Everybody keep healthy.
Yes. Thank you. Bye-bye.
Bye.
Bye. Thank you.
Yes.
Bye. Bye.
Bye. That's all your participation today. Bye.